The Scleroderma paper was published in the British Journal of Rheumatology. It's like as good as it gets. And that's thanks to the head of rheumatology at Leeds Hospital and Walter Gregory.
Thank you for subscribing to the Frequency-Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn McMakin.
I remember meeting with a business consultant about 15 years ago. And we were going through logistics. I was close to joining a big practice in Calgary. And she said, it really just boils down to two feelings when it comes to business. Either it should give you energy or it will deplete your energy. And if it's giving you energy, that's the right decision to make. And so doing this podcast is just like that. When everything is chaos on Wednesdays, it's, oh goody, but I have the podcast at 3.
Yeah, it's good.
And everything will be good at 3 o'clock.
And I started out in theater when I was 12. And curtain goes up at, in this case, 3 o'clock. And backstage, people are half dressed, trying to finish memorizing their lines. The tech guys are going, wait a minute, when does this go on? And it's like total chaos. And at 10 seconds to 3, it's like having one of those snow globes. And then all of a sudden, all the snow settles and everything's perfect.
And then after the show, then the chaos will be there right where you left it.
Oh, and then everybody forgets about the chaos because the show went so well that we all just sit around and pat ourselves on the back and be really glad that what's his name forgot his lines and somebody else came in and caught him up until he remembered it. Stuff like that. It's normal.
Yeah.
I have to tell you.
You get to tell all the things. We have so many stories to share today, so you start.
This one was, I never go on Facebook. I rely on you guys to monitor it. This week, sorry, there's a light on that's not over here. You know that this, wait, why does my face look like that? There we go. Now I'm not dark. The patient came in and when he was 8 months old, no, actually, when he was born, emergency C-section, he had blood in his lungs, and whatever they did to resuscitate him appears to have cut off the blood supply to both of his kidneys. So he needed a kidney transplant. He had peritoneal dialysis for 8 months, and then they did a kidney transplant with his mother as a donor, and then he was a regular boy, just a boy that needed peritoneal dialysis and a G-tube, failure to thrive, didn't do well, too much stress, why would I digest my food if I'm going to die, kind of stuff.
Right. Yeah.
And he said, I have PTSD from all of that. I have 1 kidney, and my major complaint is anxiety. Really? So we're going through the history, and I put the tuning fork in the middle of his forehead. His major complaint is anxiety. He's 33 and doesn't have a driver's license because he can't read. He's had 2 neuropsych evals that said he's just can't concentrate. No reading comprehension. And I put the tuning fork here. Turns out, oh, and then tuning fork next to each ear. He could hear it on this ear, but not that ear. And come to find out, when he was 5 years old, he crashed on his bike and it landed he landed on his left eyebrow, spun it, or maybe it was right eyebrow, spun his head and whacked the side of his left side of his head on the gravel, dirt, street, whatever. And I said, do me a favor, fill this out. Now, when I did the follow my finger with your eyes thing, they didn't bounce. It happened when he was 5. His brain is so good at suppressing the bounce. But when he said he didn't have any reading comprehension, what he meant was, I get to the end of the sentence and I don't remember what I read in the beginning. Or I'll read 4 sentences and in 30 minutes, I have no memory of what I read. And I said, so then I explained the connection between this. I said, what you have, a vestibular injury, had him fill out the PHYS 35 over 18. And then I explained everything they told you about what's wrong with your brain is wrong. This is why you can't remember what you read. These might help. This is your reading, and comprehension retraining program over the next year after you get your glasses. But he went from 0 self-esteem. I'm a dummy. I can't remember anything. I'm brain damaged. I'm defective. Blah, blah, blah. To the biggest grin and the craziest sense of humor. And he has gout because the kidneys filter uric acid out of the blood. His one kidney isn't doing a great job of that, so he has gout. But the first thing I did for him was get rid of his abdominal adhesions. He had a G tube, he had a J tube, he had peritoneal dialysis, and he had a kidney transplant when he was 8 months old. And I saw him, this is Wednesday. I guess I saw him twice. We got all the scar tissue done on Monday. We treated gout, just the standard program on the auto care on Monday. And then yesterday I got on his big toe and got it to work. But the most fun was who he turned into when he found out he had a vestibular injury. Because when he walked in the door, it's like, what do I have to live for? And so my post on Facebook was, I saved somebody's life today by being able to diagnose a vestibular injury.
Right.
And his only recognizable symptom was anxiety and lack of reading comprehension. Did you ever fall and hit your head? When I was 5. Okay. And then I had this car accident when I was 16. When I was on a bicycle and got hit by whatever. But anyway, it was the 5-year-old one. Isn't that cool?
Yes. And so interesting because that he found you, right? First of all, like that's always just, I don't think we give enough credit to the start of the story sometimes of the people that find FSM practitioners, especially you. It takes a lot of courage to seek out help for something, especially something as fluid as anxiety. Anxiety shows up in so many different ways, and so many people are just told that they have to live with it, and it is something that they have, and they wouldn't necessarily think about seeking out somebody like yourself for help like that. And for you to put those dots together and to go back into the history and to see it as a vestibular injury. For me, what I'm hearing, your big take homes were the reading comprehension plus the anxiety plus the head trauma. All was like, let's just.
He can't go to concerts, but he can go to the mall, can go to the grocery store, no problem. His eyes don't bounce. His brain has learned to suppress the bouncing. But what made me excited is that everybody that's been through the core, you may not remember, and everybody watching has probably been through the core or thinking about it. There's 7,000 people in the country, in the world, that know about vestibular injuries. This kid went to 2 neuropsychologists. Neither one of them knew anything about vestibular injuries. That's just wrong.
Yeah, it is. I'm not sure. Maybe they know about it, but maybe they think they can't treat it. So what's the point?
They can't know about it. Or when someone has trouble with reading comprehension, it's a screening test.
Yeah,
It takes a $19 tuning fork and a finger. That they're just, all you have to do is screen for it.
yeah,
Do you have it or don't you? And how do we know about it? And the inner ear participates or creates the transfer of information from short-term to intermediate term to long-term memory. And I said, and your memory just never makes it.
right.
So we'll have this conversation, and in 30 minutes, you won't remember it. So I will write down the guy that you need to see, and you'll remember where you put the pieces of paper. And we talked about how to manage. This is a management problem.
Yeah.
I don't want to have this. And I said, we don't get to vote. It's a done deal.
And I think that is a common complaint. I don't want to have this. I don't want to deal with this. I don't want to do this. And I don't want to sweep up dog hair, but this is where I'm at.
And I wouldn't want to deal with it if I was you either.
Yeah.
Why would you want to do that? I'd worry about you if you wanted to have it.
Right. Right. Like that's a really good point. Like your feelings towards this are completely normal and to be expected. And I think that we talk a lot about being careful with our words as practitioners and to not say things like, I don't know what's going on, or ooh, or that's weird, or we never want to make anybody feel worse than what they already do. So when they do say something like, I'm so fed up with this, I don't want this, to normalize that and validate that, I think is a really important component of care myself.
Yeah, that's, of course you don't. And this is how we're going to manage it.
Yeah.
This is how it's done.
So let's talk about this. Are you going to see him a few more times?
I see him, we have a 2-day practicum coming up Saturday,
Right.
Sunday. So I take Friday off except for one patient with Ehlers-Danlos who is then going to come to the core.
Yeah.
And then, so I have him tomorrow. So we dealt with horrible gout in his big toe. And he said, is it going to come back? And I said, you have 34% kidney function. Of course it's going to come back.
Yeah.
What? You mean you can't make it not come back? And it's like, no. They're using a new IV drug on him that his uric acid went from something like 18 down to 0.2
Wow.
in 2 or 3 days. It's pretty amazing. I can't even pronounce it. There's an X and 2 T's in it someplace, or maybe it's 2 T's and a Z. I don't know. But it's no, oh, I know the other word that he said, boy, I love this part. I bet I'm the worst patient you've seen. It's, oh no, matter of fact, you're probably the easiest patient I've seen in 2, 3 months. He said, what? I said, well, think about it. You can see, you can chew, you can swallow, you can hear, you can eat, you can pee, you can poop, you can walk. Yeah, but my toe hurts. You can walk. Oh, look at all the things you can do.
Yeah.
And what you have is incredibly inconvenient. Inconvenient is a really useful word.
Yeah. Yes, it is annoying. Let's call it what it is, but inconvenient is doable still.
Mhm.
It's not optimal,
It's,
but for
it's
sure.
manageable. It's
Yeah.
manageable.
Yeah. So would you suspect that, again, we're going back to this management problem, this would be something or custom care to be used like every day to help with
Yeah.
something like that? And so vestibular, what is a general prescription for usage? I know it depends because vestibular symptoms are this crazy rainbow of it's a big spectrum.
Sorry, something over there is buzzing.
Oh,
I think Kevin's laptop might explode.
oh no.
So the thing that I used on him was 40 and 44.
Yeah.
Quiet the inner ear. It
Yeah.
relaxes the neck muscles. The anxiety just goes away. I ran concussion in Vegas, and he came in with his voice at a tenor. And by the time we finished with concussion in Vegas, and I probably spent 2 hours taking apart abdominal adhesions at the same time running concussion in Vegas twice, 40 and 44 for 2 hours. And at the end of that, he was a baritone.
Wow.
And the scar tissue on his abdomen didn't hurt anymore. It was pretty fun. And
So
that is
there's all these distractions. I have a panting dog. I have banging on the roof. We're getting a new roof put on. So there's all these things for my little brain to have to filter right now.
so many distractions, so little time.
Right? Kevin's on the move right now with his computer.
Yes, he's out in the hallway, but he's going to be fine.
Everything's going to be fine. So again, like I think when we talk about head trauma, motor vehicle accidents, slips and falls, right away, a lot of us think about concussion and the concussion protocol. But when you start putting the vestibular screen into play, I do think the two protocols match up quite a bit. And running the 40 and 44, again, quieting that inner ear.
Relaxes the neck muscles.
Yeah. And when, for me, it feels like the vestibular people's, especially the scalenes, I don't know why they're affected so much. It's like they're holding on for dear life.
Yeah, the brain, whoops, oh, don't do that. The brain is desperately trying to get more input, need input, proprioceptive input about where it is in space.
Right.
And so the neck muscles all, oh, I have Ellie. Sweet. The neck muscles get really tight so that the brain has more proprioceptive input. And the other clue to go looking for a vestibular injury in the absence of a complaint about anxiety or any of the other things we associate with vestibular injuries is multi-level discs and facet joints. So if you have disc bulges at 3, 4, 4, 5, 5, 6, and 6, 7, auto accidents, you get 5, 6, and 6, 7. But 3, 4, and 4, 5, that's awfully high. And then facet compression and facet joint pain, if you crank down on the muscles in the back and you crank down on the muscles in the front, you put the whole column under compression and you get disc bulges at multiple levels. That's the other thing that makes me go looking for a vestibular injury. So the concussion protocol, concussion in Vegas is one thing, but that is entirely different than 40 and 44. You
Right.
wanted to calm everybody down because the brain is freaked out because it doesn't know where it is in space.
Yeah.
But you can treat 40 and 44, quiet the vestibular system. I have one version. So there's one of the standard protocols is neck pain. I have neck pain plus vestibular. That's an extra 20 or 30 minutes long because the first 30 minutes is 40 and 44.
30 minutes, yeah.
So you relax the neck muscles, then you can go in and do the supine cervical practicum with your fingers.
Yeah.
Until these muscles are loose, there's almost no point.
Right, because they're splinting or they're tight because they are reacting to something. Again, like if it were so easy to just treat muscle and not search for the cause of what's making the muscle tight, we could do treatments in 7 minutes and we'd only need a handful of frequencies.
Yeah,
But what fun would that be?
it's true. It's you have to like solving puzzles.
I love solving puzzles. Speaking of puzzle, we have a quick question. I want to stay on top of the questions a little bit here. So it says here, a patient was using quick grip glue, an organic compound, created severe dizziness and severe dizziness and balance problems. Used 40 and 900 with 44, and then used 4089, which made a difference. Sounds like I should have used 94 109 also. Anything else useful? Take a little while to read that.
Yeah, I have done something very strange to my question and answer thing. Did you fix it? We think the dizziness is not likely to be the vagus. The dizziness to me is the inner ear or the midbrain, because remember that pathway that Dr. Rusky showed?
Yeah.
Eye, ear, it all goes to the midbrain and then to the cerebellum. So the midbrain's involved in that pathway. So quick grip glue is very aromatic, a lot of organic, volatile organic compounds, VOCs. So you'd run 57, 900, 920. 900 was a good guess. And I would tend to run them on the cerebellum, the midbrain, what was the other symptom besides dizziness and balance?
Yeah, I just said dizziness and balance. That's it.
Yeah, then the cerebellum, the midbrain, maybe the inner ear, I wouldn't think, because it's something, VOCs you inhale, they go to the cortex, and then they just follow the blood supply and hit the midbrain. And from there, maybe the inner ear or the cerebellum, because the midbrain gets input from the inner ear and the cerebellum, or vice versa. So I'd use 57, 900, 920 because we're talking about organic chemicals and toxicity.
Yeah.
And see if that helps. Some people are really sensitive to it, especially if they have mitochondrial issues and they can't detoxify stuff. So you'd do, what would you use? Lipoic acid, CoQ10, vitamin C, all the antioxidants in that antioxidant chain. It's amazing the number of things that we now have in the core that are useful kind of in so many situations. The only trouble is there's 950 or 1,024 slides in the core.
There is a lot to go through. Not going to lie about that.
And we talked about, give me your opinion about this. We talked about taking out the whole intro section, like everything before the first break. And they have to finish those slides and check, I read these slides or watched this video or did whatever.
Yeah.
And then we'll start, it just makes it all shorter. It's just exhausting for people at the 5-day core.
For sure. I think that's what we'll be doing with the sports course. There's a lot of the theory that I think people should just watch the video and read the slides and get that done before you come to the course so that they just have a stronger foundation to do the fun stuff with.
Yeah. And then we have time for Q&A.
Yeah.
So that's good.
Yeah.
So we can always ask, okay, you watch those 87 slides or 67 or whatever. Do you have any questions about it? Any parts of it that you don't really grok or get?
Yeah.
I'm dating myself by using the word grok, I think.
Nope. No, we're gonna bring it. It's cool.
Coming back.
I don't know if it's ever really left. Like, how about that? I've used it consistently.
Oh, good.
Yeah, I think too, I would just to go back to the dizziness and the balance as you're using those frequencies, then I would, I would challenge again the balance with after you've done the 4089, we talked about the sensory motor cortex and the cerebellum. So that's also important to support that, even with standing. So we do that with the sports course with just standing on a flat surface, feeling your feet. You could even hold a washcloth in each hand and stand in Superman pose. We do that quite often. And then you're running.
Oh, yeah.
Then you're running. Yeah. Then you're using 84, the cerebellum.
Right.
Another question popping up here. Referral that has been diagnosed with Wegener's granulomatosis. I've not seen this person yet, but I'm wondering if it's safe to treat. I've not talked to this person yet, but from research, there really is a serious condition creating vascular inflammation in small and medium-sized arteries.
Yeah, Wegener's, the only Wegener's that I ever treated. Kevin, how do I get this smaller? How did this get big?
Yeah, just
Oh,
there you go.
there we go.
Technology today is just being silly.
Yes.
Wegener's in the patient, the only patient I've ever treated with Wegener's presented with something that was very much like CRPS, I think. It was a million years ago.
Right.
And it is a tubercular constitutional type because granulomas that form in, yeah, and that's what gave her the CRPS was vascular inflammation in small and medium-sized arteries. It's, of course, you should treat it. We have a frequency for small arteries called capillaries. That's 162. And 62 is arteries, which I guess would be medium size. And inflammation, you have a frequency for that. We know that works. Granulomas are, that's one of those things I'd Google because my idea about it is like tuberculosis. The tubercular constitutional type forms oh, now I know what you're talking about. Kevin asked me how your presentation went. Was that this week? Oh,
It
goody.
was last weekend, yes.
Okay, hold that thought. Anyway, it's encapsulated. And so 42 is the tubercular constitutional type. And that in particular was what helped the only patient I've ever treated with Wegener's. I guess you treat fibrosis, maybe 91, hardening. Encapsulation is 681 from the advanced. 58 is degeneration. They're not dead, so it's not necrotic.
Right.
Even if all you do is reduce inflammation in the arteries, and the arteries have nerves that go to them, so you'd have to treat 40 and 396 at the same time, reduce inflammation in the nerves.
Yeah. That makes sense.
Yeah. How do you get the slides and the videos to watch? Sign up for the class. Kevin sends you, he doesn't have the first chunk of slides. He'll send you all of the slides. And then he and I, before the next 5-day, remember we talked about taking out the whole first intro section? And I have that. And then I have to send that to you, and then we have to decide what we're going to do with it. But when you sign up for the class, you'll get the slides and the video before you ever take the class. And I strongly suggest that you watch them before the class, because the class is easier. It really gets easy around the fifth or sixth time you watch it, but it's so much easier if you've already watched it once. And
And
then
same goes for the sports course. For the hybrid models, you get the videos. But we're not going to be doing too many of them because we're changing the sports course and the rehab so we can spend some more time. But even in those cases, I think we'll do some of the prerequisite slides because I'd like to spend those practicum weekends just doing practicums. So yeah, sign up for the classes and you'll get all the yummy videos to watch forever and ever.
yes, tell me about your big dog presentation.
Yeah, it was very interesting. The conference it's in Newport Beach, so it's very laid back. They had this very cool surfer-esque vibe for the conference room. The the presenters were amazing. Everybody got really short little blocks of time, whether it was half an hour or an hour, so you could just get a little snippet of what they do. And most of them were chiropractors that kind of had their own courses as well. There's like foundation training and DNS, which is very interesting to me, dynamic neuromuscular stabilization. So using a lot of patterns we do as infants and babies in crawling and incorporating that. The tie-in to FSM works beautifully. So it was great to meet everybody in person. And when I got up there, the course I presented on the second day, and there are no breaks. They don't have any coffee breaks. There's no lunch break. There's no dinner break. It's just
That's cruel.
from 10:30 all the way to 9 p.m. And the room is split. So there's like a vendor side. So it was hard to kind of corral attention, I guess you could say, because people wanted to look at the vendor booths and have these other conversations. So part of being a presenter is reading the room and seeing whose focus you have. And with your help with those slides were fantastic and necessary. So half my presentation was gifted from you, and I appreciate that. Just with the data and those quick facts were great. When you see those slides with IL-1 and substance P and why the beta endorphins go up. It was just those quick facts that people were like, oh, I want to do this. And it was on the tail end. A lot of our presentations dovetailed together. It was very anti-ice, very pro-heat, pro-movement. I jumped on that because I'm like, yeah, we don't want people to sit with an ice pack on their knee if they can sit with FSM and let the macrophages do their job. So right away you saw people light up. Like I said, I was standing around the first day a little bit, but after I spoke, there's tons of people coming over to my little corner, and I had all the devices there so I did these little mini treatments. I had concussion in Vegas running a little bit. I had vitality in the fascia, there were a lot of Eldoa and fascia people there. So they can feel when the fascia starts to feel nice and gooey. We were throwing the word thixotropic change around quite a bit. So I was speaking everybody's language.
Yay.
But I guess like the big moment for me, it was just funny how it came full circle, was Steve Capobianco introduced me, and he is the CEO of Rock Tape. And he's somebody I greatly admire. He's always improving tape, and even though he's still very much involved with Rock Tape and the progression, but he has some very good courses out there. So if people are looking to take online courses with functional movement training, his FMT course is fantastic. But his introduction was very special to me because I was the biggest skeptic of Rock Tape and kinesiology tape. I was the biggest skeptic of FSM. So it's just very funny how both those things, and I will not treat without FSM, and I barely let anybody walk out the door without rock taping them, because I really do feel the changes that we create with FSM sometimes work too fast for our proprioception to understand. I do firmly believe that, and I feel that the kinesiology tape is very helpful of giving that neurofeedback to say you're safe, you're supported, You can move, it's not adhered. So it was very special in those two regards. So yeah, I felt good speaking. I was really blessed to meet so many amazing practitioners, and I think I did you proud.
I think you did you proud. You always do me proud. This is
People,
great.
and if you can go back and look at the conference on demand as well. So it's if you go to sprttherapy.com, you can get all the videos, and they all have the C or the yeah, your continuing education credits approved. So there's lots of amazing things you can check out there. So
So cool. Yay.
yeah, thank you. A couple more questions here too. Let's go back to Julia. Dr. Carolyn Kim, I ran the frequencies you suggested for my jaw pain last week for an hour. Didn't feel any improvement right away, but it started to work the next day. Great. And now a week later, he's about 80% better.
Yay.
So I do want to talk about that. I think sometimes we expect those instant results, and that's great. But I always tell people before you write off the treatment, just give it a day.
Do you remember the patient we had in common? The one that used to live in the Bay Area, then moved up to Seattle, and
Yep.
it had all the jaw and face and twisty things. He has a disc bulge. So he drove me crazy. He drove you crazy. And then I'm not sure exactly what he did, but then he did the physical exam, and he has hyperactive patellar reflexes and increased tone in his legs. He has a right-sided C5-6 disc. So we ran 81 and 10. And then he said, and I've got this TMJ, can you do something with it? So I did two machines, 124 and 100, because he had those braces on for 5 years, and they pulled out the teeth, and then they did all that stuff. 124 and 77 for the pterygoid, 124 and 100, and then while those are running, I can't remember what I treated downstream, but then I went back up to his jaw and said, "Are your hands clean?" And he said, "Yeah." I said, "Okay, take your fingers and put them on your palate and separate it, because all the muscles in his face, his temporalis, were just jammed." So he, of course, always being in a rush, went hard and fast. I said, "No, 1001, 1000, slow and soft." So he started to do this. Eduardo would be very proud of me. And as he did that, I reached here, and at a third machine running on scarring in the dura, but I was able to reach here and lift his frontal bone up, separate this, separate that, but we were running disc repair around his neck, 81 and 10 to get rid of the increased tone on the right. And at the end of it, I made him go in the bathroom and look at his face. It's completely different.
Wow.
But your TMJ question reminded me of that. It's just,
Yeah.
I wonder sometimes when you treat the TMJ, after you soften the muscles, just the act of chewing and moving your eyeballs and sleeping on one side and then the other and then the back and then tipping your head forward with your jaw relaxed, with these muscles relaxed, is the next step to adjust the cranials.
Right. If we look at it just from a fascial attachment perspective, we learned so much with Eduardo's presentation on how the fascia, things just don't stop at the suboccipits. It runs all the way up and in. Like you said, if you're having somebody with all that adhesions and congestion, and I can think of a whole bunch of other words to describe what's happening in the facial bones, along with what's happening with the disc, just that protective mechanism that's happening. It's not just happening in the jaw. That's as silly as just treating a knee without looking at the hip or the ankle.
Yeah, it was fascinating. The other thing you reminded me of, almost there, when they talk about being able to integrate the nervous system with rock tape and whatever, this kid that I was working, anyway, the one with a really bad gout, like this toe was just so painful. And he said, as I'm moving it, the pain's gone down, movement's improving, I'm treating scarring in the joint capsule, ankylosis in the joint capsule, scarring and hardening in the cartilage, and increased secretions in the endothelium, right? What is rheumatoid arthritis? Endothelium is the lining of the blood vessels. 386, whatever 386 is.
Synovium?
Synovium, thank you. The synovium. So increased secretions in the synovium, and I'm sitting there moving it and asked him to move it, and he said, I'm afraid to. I said, oh, okay. So leads in the same place from his knee to his toe, and ran 40 and 89 and moved it passively, and it didn't hurt. And I said, now you try it. Oh, that's easier. What'd you do? That's all, we just moved it. And then his plantar flexors had not contracted in 8 months.
Wow.
Ever since the acute gout. So we had to do 81 and 84.
Yeah.
Increase coordination, stop being afraid of it. What lubricates a joint? How do you get the cartilage unstuck? Secretions, lubrication coming from the synovium, right?
Yeah.
And it's so fun. I'm just jealous because I don't know how to use rock tape, but I'm glad I don't know how, because then I have to do it with FSM instead. I'm forced.
I do it in conjunction. I think the two are just the most amazing adjuncts and catalysts. I think taping works better with FSM. I think FSM works better with rock tape in some situations. I don't tape everybody. I tape a lot of people though. And it's funny, even my elderly patients, because I have all these different colors, they like it. And I think it's especially helpful for like plantar fasciitis. I think it's helpful for especially cervical spine. Sometimes when we do too much with the neck can feel a bit discombobulated after. And so having a couple strips of that tape can give that nice feedback of, yeah, I get it. Everything feels mushy and soft, but you guys still have a job to do and you have to lift up this head and you have to rotate it and you have to all play together in the sandbox nicely now.
And you can take that online.
You can, yes. Yeah,
Oh,
he's got
that's
some
good.
fantastic online courses. And he's such a wonderful teacher. That is one thing that I've always just admired so much about you, because it's one thing to know something and know something very well, but it's another thing to teach it. And again, that voice of what you want to say is not what they need to hear. And you were right. You had texted me about that presentation. Like, there's going to be a lot of things you're going to want to say that you just can't right now. And I'm like, she's totally right. So I blew it up a couple times and it was a lot more of your content. And I thought, my content is there. And when they're ready for it, I'll be waiting for them.
Even I suspect that my content was framed within your context.
Yes.
And that's like, what's in the slide doesn't get, speaking of teaching,
Yes.
Scleroderma paper.
Yes, we have to talk about this.
The Scleroderma paper was published in the British Journal of Rheumatology. It's like as good as it gets. And that's thanks to the head of rheumatology at Leeds Hospital, and Walter Gregory. Walter finally wrote up the paper. He and I did the research together. Then he did a second set, and he has somebody that helped him treat the second set. And he said, Catherine can teach the OTs and the PTs at the hospitals in the region. And I said, I'll fly over. And I know she's good at doing, but I'm good at teaching, and it's a different skill set.
It truly is. And I'm learning every time I present what needs to be said, what needs to be said twice and 3 times, and where do I pause for the effect, because it's very important that they heard that last sentence properly. It's just very exciting.
Isn't it? And after about 10 or 15 years, you feel pretty comfortable. It comes on.
It's taken some time. Yeah. I will say a couple more questions here before we leave. Allie,
Okay.
how would you treat someone with stagnant blood flow who is on mild antihypertensives? The only thing that has been found possibly underlying the high blood pressure is the blood flow being slow and stagnant.
Mild antihypertensives are usually diuretics, and blood flow being slow and stagnant sounds like an oriental medicine way of looking at it. So I was a pharmaceutical rep, so I talked about antihypertensives for 7 years. And according to Mark Houston, hypertension is a normal response to endothelial damage. And so that's his idea about it. The mildest antihypertensive is a diuretic, and whoever decided that the blood flow is slow and stagnant might be feeling the dehydration. Blood is supposed to be 70%, 80% water. There's a lot of liquid in it. Check for congestive failure. So if it's not pumping enough, they don't usually have hypertension. Yeah, there's more questions there. I guess the safest thing we can do in this situation, check what they're taking, and literally in front of the patient, look up the side effects of that medication. And the other thing that's safe to do is run the basics, inflammation, and increased secretions and vitality in the arteries, and to some extent the capillaries, to restore the laminar flow. So especially if the patient if all this started after COVID, because it makes the endothelial lining of the blood vessels just not smooth, and things get rumbly. They don't make clots necessarily, but would give me.
Right. Oh, we have a great thing about Raynaud's popping up because that was in the Scleroderma paper, I want to say.
I'm sorry, I'm stuck on
The one above?
anonymous attendee.
Okay. Lady who's 78 was given 5 infusions of iron on 5 consecutive days. The doctors failed to record that they had given it, so they just kept repeating. She now has no short-term memory. Tried all the usual brain frequencies, but nothing seems to make a difference.
There's a frequency for removing iodide, and I think iodine. You can try that. Iodine's iron, pretty sure there's a frequency for iron. It did start after COVID. I think there's a frequency for iron. Run it in the blood supply, the midbrain, consult a malpractice attorney. And it's like, what caused it? The first real question is why somebody that's 78 is iron deficient. So did they diagnose it correctly? Does she have microcytic anemia, or macrocytic anemia. It's normal for a 78-year-old to be macrocytic, which is not enough B12. Microcytic is not enough iron. And sometimes they get confused about that.
Yeah.
Except for looking for the frequency for iron in the advanced, and then take that out of all the brain parts and the blood vessels, and
Iron is 5.
5. Okay. Yeah. So try that.
And then the last question, any tips for treating Raynaud's?
Raynaud's is also covered in the new
paper.
paper.
Yes.
So you treat the blood vessels and the sympathetics. So treat the arteries especially. Did you know there's no sympathetic innervation to the veins?
Really?
Yeah,
There's no sympathetic
makes sense, right?
Yeah, as I'm saying it out loud, I'm like, I guess it's good that those guys are just unaffected. But I have Raynaud's, and it's been so much better after treating my vagus as much as I do. And my biggest trigger is going to Costco. That's what causes my Raynaud's to flare up. The last 3 attacks that I've had have been at Costco.
What happens when you put a tuning fork in the middle of your forehead? Oh, hockey player.
Oh, I'm sure. I'm sure I know what's causing it. It's again, pattern recognition. I don't know if I would have put things together as much as I do because of what we do.
Mm-hmm. Yeah,
We're both teaching this weekend. You've got your weekend. I have the sports hybrid course this weekend in Santa Cruz.
Oh, goody. Oh, I love Santa Cruz.
Yes, so we have a wonderful PT that's going to host it for us. So it's going to be a small, fun group. We have the sports on the Saturday, and we're doing the sports advanced on the Sunday. We get to have lots of fun. Yes, and you're going to have all fun at the Practicum weekend.
We have a Practicum weekend. How many people are coming?
15.
15. So it's just good sized class.
It's a great class.
Yeah.
You want to have, especially for the Practicum weekends, time to play and have attention and really feel good about your skills. So that's fantastic.
Yay.
Yay.
Us.
Good. Well,
You'll have to be going on.
Yes. It is.
Thanks, Al.
Great. We will be here next week, I
We
believe.
will. Yeah.
We're just cranking these podcasts off.
It's always nice when we're in the same place at the same time.
Yeah,
that always helps.
I love it.
Yay.
Okay, everybody. We will see everybody same time, same place next week.
See you next week. Bye, sweetie.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.